We have some early experience with some second-generation TAVR devices, including what we're talking about here is the Evolut R, or recapturable device. And I'd like to introduce you to Ian Meredith, MD of MOnash Medical Centre, Southern Health in Melbourne, Australia. And we're talking about a whole new trial. You've done only a few patients so far. Tell me about the device first off.
Thanks very much. So the new device is called the Evolut R device, and it's really a third iteration of the CorValve, which is Medtronic's major self-expanding transcatheter aortic valve. So this valve has three new features. It's been redesigned so that the valve has a better inflow section to the valve, and there is a new delivery catheter, a new handle, and also a new way of mounting the valve onto the delivery catheter. The big change, though, is that the valve is recapturable and retrievable, and indeed partially resheathable, so that you can actually reposition it. I know that's a lot of R's, but that's how it works, is that you have the ability to recapture this self-expanding valve into the frame to allow you to do minor repositionings to get it in the right place at the first point.
Now, does it complicate the procedure any? Does it make your job harder or easier?
Well, actually, it makes your job easier, because you're always fearing that you're not going to get it in the right place. Yeah. So that once that is taken off the table, because you know you're going to get it right, the job is already easier. You know that you're going to get a good result. It's just how and when. So the ability to reposition it is usually something that you would do early in the procedure anyway, right, just to get it in the right place before you fully expand the valve. So this valve has the ability to be completely recaptured to about 80 or 90%. So you can have 80 to 90% of the valve in its final position. And if you don't like that, theoretically, you could recapture it very simply and just start again. So that's going to give the operators a great deal of confidence. So the other features of the valve is that it's very stable when positioning it. The control from the handle is what we call one-to-one. So a small movement of the handle outside the body is transferred to the movement of the valve at the level of the aorta. So that one-to-one control, that precision control, means that you have greater confidence, and that will help the procedure in terms of the ease of performing it. So it has a different sheath mechanism, so that when you enter the body with the valve first, and then the sheath follows. So it's called an inline sheath system. So that means the hole in the femoral artery that you need as an access route, and the size of the femoral artery or the external iliac artery that you can pass through, is actually smaller. The catheter itself is very deliverable, and the handle has been redesigned. The control handle has been redesigned. It's very intuitive, ergonomic, and also a very thoughtful design, so it makes it very easy to use. Even when you put your hands on it immediately, it's very likely you put your hands in the right place. So there's a lot of thought that's gone into the engineering so that you don't look down at it and say, where should I deal with it? If you naturally pick it up, you'll be using it in the correct fashion. And it's just a small rotation of one part of the handle to neatly unsheath the valve or recapture it if you need to.
Now, you've done a few patients so far. What is planned in terms of the study?
So we've done the princely sum of 3. We did the first patient in the world a couple of weeks ago, who was a 97-year-old lady. 97, never had a day in hospital in her life, and was normally you would wonder about the justification of treating a 97-year-old, but she had been extremely well up until this point, lives on a farm, independent, and so it was a very reasonable thing to consider treating this lady. We've done 2 other cases since then. The trial will have 60 patients. It's a feasibility study with a new device, 8 sites in Europe and Australia. So we're expecting very good results from this because of its control and its ability to be repositioned easily.
Well, it's a challenge because you don't really want to have to put another device in.
Absolutely. So putting a second device inside a first device is very crude, and it's the last thing you want is a great load of metal inside the aortovalvular complex. So having a single valve is what you want, and the ability to reposition this self-expanding valve, because self-expanding valves, to recapture that once it's open, it's not easy. So the ability to recapture a self-expanding valve is very impressive, and then reposition it to a minor degree is also very important.
Congratulations, because it sounds like this could be a pretty exciting story. And how long will you follow these original patients, the 60 that you're planning on doing?
So those patients will be followed up for 5 years, but they'll form the basis of a study to provide evidence for a much larger study, of course, before the valve could be approved.
I don't have to wait 5 years to talk to you again, do I? When will you have some data, perhaps?
We'll have meaningful data, probably 30-day data on the 6 patients, probably at ACC.